Good afternoon. I'm Jennifer Hendricks, and I'll be presenting the second part of Unit 1. The material we will go over today is meant to be a supplement to the study materials and practice quizzes. This bootcamp should not replace the study material, as this will just be an overview of the material. Our agenda for today includes Medicare compliance and regulations, ethics, volume to value, financial overview, and key performance indicators. In this section, we will address specific Medicare compliance and coding issues and terms such as MS-DRG window, Two-Midnight Rule, correct coding initiative, modifiers, and Medicare secondary payer. Basic things to keep in mind regarding the 3-day window rule. Any diagnostic outpatient service is considered related to the admission if it uses the same ICD-10-CM diagnosis code as the principal diagnosis for the hospital admission. All diagnostic services and related charges provided within the window are considered to be related. These include radiology, cardiology, clinical laboratory, EEG, pulmonary function, and audiology tests. Related charges include anesthesiology and drugs used to provide radiology or other diagnostic services. Services are considered to fall within the window if they are dated within 3 days before the date of admission or on the date of admission. For example, if the admission is on Wednesday, any services provided on Sunday, Monday, Tuesday, and before the time of admission on Wednesday are within the billing window. Ambulance, maintenance, renal dialysis, and Part A services provided by a nursing home are not considered related. Under Medicare rules, certain outpatient services provided by hospitals or by entities owned or controlled by hospitals must be billed as part of an inpatient stay. These include all diagnostic tests provided to a Medicare beneficiary by a hospital on the date of the beneficiary's inpatient admission or during the 3 calendar days immediately preceding the date of admission, unless there is no Part A coverage. Outpatient services that are not diagnostic provided to a Medicare beneficiary by a hospital on the date of the admission or during the 3 days immediately preceding the date of admission. From the beginning of the Medicare program, certain payers have always been liable for payment of claims. More recently, with the enactment of the Medicare Part C or Medicare Advantage plan option, this principle has been expanded to include work-related injuries and accidents, Black Lung Program services, Veterans Affairs services, patients' enrollment in a Medicare Advantage plan, federal grant programs, public health service programs. In these cases, Medicare does not make a secondary payment. The amounts paid by the primary payers are considered payment in full. In recent years, the OIG has been reviewing these claims to ensure compliance with the MSP rules. The Medicare secondary payer situations. Working age is when the patient aged 65 or more or spouse is employed and the patient has a group health plan coverage through the workplace. GHP is a group health insurance plan provided by an employer that has 20 or more employees. If the employer has less than 20 employees, the group health plan does not qualify as the primary payer, and Medicare is billed as primary. The patient is not required to accept the employer's insurance coverage, and in that case, Medicare would be primary. The employer is prohibited from offering a supplemental policy in place of the standard group health plan benefits offered to other employees. Accident or other liability is when the patient needs medical care as a result of an accident. The liability insurance company may be responsible for payment. Automobile accidents as well as premise accidents are included in this MSP category. Healthcare providers are required to obtain the billing information for the liability carrier. Liability is primary only if the accident did not occur on patient's own property and if the patient states there is liability. Required coding on the UB04 includes the occurrence code and the date of the accident. If no medical payment or other third-party coverage exists, occurrence code 05 and the date of the accident or injury must be provided. Disability is when the patient is eligible for Medicare due to a disability, is under the age of 65, and has group health insurance coverage through a large group health plan. A large group health plan is a health insurance plan provided by an employer that has 100 or more employees. Patient is under the age of 65. Patient or spouse has current employment status with employer If the employer has less than 100 employees, the group health plan does not qualify as the primary payer, and Medicare is billed as primary. End-stage renal disease is when the patient has permanent kidney failure and is covered by a group health plan and has not completed the 30-month coordination period. Please note that after completion of the 30-month coordination period, Medicare becomes the primary payer unless another MSP condition exists. Insurance must be a qualifying group health plan, and it must still be in the 30-month coordination period. The Medicare program only pays for medically necessary services. Therefore, providers are expected to screen outpatient services for compliance with Medicare coverage rules. If an ordered service does not meet medical necessity based on the test and diagnostic information provided, the provider is required to issue the appropriate advanced beneficiary notification, or an ABN. The patient must agree to pay it, and if we don't obtain the ABN, then we cannot bill the patient. An ABN must follow the wording provided by CMS to ensure that the text is easily understood. It must clearly identify the specific test or services identified as non-payable. It must provide the information used to determine that Medicare may not pay for the service or service previously identified. It must be provided to the patient far enough in advance to allow time for the beneficiary to make an informed decision. It must be understood by the patient or the patient's designee, and it must comply with the use of the form provided by CMS for this process. Traditionally, the decision to admit a patient as an inpatient has been up to the judgment of the treating physician, with oversight from the hospital and input from the patient. CMS recovery audit contractors and Medicare administrative contractors had a tendency to second-guess physician judgment, declaring that some patients who were admitted should not have been. This has created ambiguity over who decides what constitutes an appropriate admission and what the criteria are for making such a determination. So we got the Two-Midnight Rule. In order to promote the use of correct coding methods on a national basis and prevent payment errors due to improper coding, Centers for Medicare and Medicaid Services developed the Correct Coding Initiative. The purpose of the Correct Coding Initiative is to ensure that the most comprehensive groups of codes, rather than the component parts, are billed. The program consists of edits that are implemented within providers' claim processing systems. The CCI edits are incorporated within the outpatient code editor. The edits also check for mutually exclusive code pairs. The unit of service edits determine the maximum allowed number of services for each healthcare common procedure coding system code. Using a modifier allows a hospital to indicate a specific circumstance that has affected a procedure or service without changing its definition or code. The appropriate use of modifiers reduces the need for separate procedure listings on a bill by describing the modifying circumstance. Please keep the following points in mind. The 3-day DRG window rule requires certain outpatient services that are provided within 3 days of the admission date by hospitals or by entities wholly owned or controlled by hospitals to be billed as part of an inpatient stay. The purpose of the ABN is to inform a Medicare beneficiary before he or she receives specified items or services that might otherwise be paid for that Medicare certainly or probably will not pay for those services or items on that particular occasion. The situation where Medicare acts as a secondary payer would include working aged, accident or other liability, disability, and stage renal disease. In order to promote the use of correct coding methods on a national basis and prevent payment errors due to improper coding, the Centers for Medicaid and Medicaid Services developed the Correct Coding Initiative. The purpose of the Correct Coding Initiative is to ensure that the most comprehensive groups of codes rather than the component parts are billed. Our section 1.6 question is, in order to promote correct coding, CMS developed what? The correct answer is number 1. The purpose of the Correct Coding Initiative is to ensure that the most comprehensive groups of codes rather than the component parts are billed. The program consists of edits that are implemented within providers' claims processing systems. The Correct Coding Initiative edits are incorporated within the outpatient code editor. The edits also check for mutually exclusive code pairs. The incorrect answers are 2, 3, and 4. ABN is related to medical necessity. MSP identifies who is primary and who is secondary. And adding modifiers are a modification to an existing HCPCS code without having to add an additional HCPCS code. In section 1.7, we will address business or organizational ethics and the application of ethics in healthcare and the revenue cycle. We talk about ethics for many important reasons, such as the expanding global economy, increasing workplace diversity, instantaneous media coverage, and unique generational differences. As a result, defining and applying ethical business practices and principles is important to all industries. Healthcare services are important to both individuals and our society, and as a result, healthcare providers and those that work in the healthcare industry have additional ethical duties to the patient and the communities that they serve. In healthcare, patient and consumer expectations, public scrutiny of providers, increased legislation, entitlement programs, and socioeconomic issues may increase the complexity of adhering to the code of conduct on a daily basis. Examples of ethics violations that impact the revenue cycle include financial misconduct, overcharging, theft of property, falsifying records to boost reimbursement, miscoding of claims. Provider policies and procedures should be in place to reduce the risk of these types of violations. However, it is just as important to be aware that an individual's experiences and value system may impact his or her actions and result in non-compliance. Some HIPAA examples of ethics violations include using personal email to transmit patient information, accessing a health record for reasons unrelated to your specific job duties, as well as accessing your own medical record. Business ethics or organizational ethics represent the principles and standards by which organizations operate. Business or organizational ethics are relevant to the conduct of individuals within an organization. Examples of ethics violations which may occur that impact the revenue cycle include financial misconduct, overcharging, theft of property, falsifying records to boost reimbursement, miscoding claims. Other points to keep in mind include ethical behavior, which is considered to be actions that are the right thing to do, not just what is required by law, regulation, or rule. It is very important in healthcare. The concept of ethical standards applies to actions that are expected by each individual staff and management member within healthcare. And it is important for staff and management to uphold the business ethics of the providers and act as peer role models. The 1.7 question is, what do business or organization ethics represent? The answer is number 1. In healthcare, both clinical and financial personnel must be fully aware and engaged in the laws and regulations that govern their work. Business or organizational ethics are relevant to the conduct of individuals within an organization. In section 1.8, we will address the broad provisions of the Affordable Care Act of 2010, CMS's proposed alternative delivery and payment models, and standard quality measures. The Patient Protection and Affordable Care Act of 2010. The Patient Protection and Affordable Care Act, also known as the Affordable Care Act, or ACA, was passed and signed into law in 2010. It was designated to reform the healthcare system into a system that rewards greater value, improves the quality of care, and increases efficiency in the delivery of services. The Act includes provisions to improve the quality of care, reform the healthcare delivery system, encourage pricing transparency, and modernize financing systems, and address the issues of waste, fraud, and abuse. There are more details in your online CRCR course materials. Improvements include reducing hospital admissions, reducing hospital-acquired conditions, comprehensive joint replacement and cardiac services, and improving physician quality reporting. Over the next 10 years, these improvements will not only improve the quality of care provided, but also reduce Medicare spending by more than $15 billion. Another cost containment provision of the ACA is reforming the healthcare delivery system. Reformation of the healthcare delivery system includes establishing regulations for the development and financing of accountable care organizations and developing new approaches to payment and delivery systems through the Center for Medicare and Medicaid Innovation. This slide shows the legislation and the programs that have been put into place over time to control the cost of care. The Center for Medicare and Medicaid Innovation is charged with the ongoing development of new models for delivery and payment of services. Targeted innovations involve quality improvements and/or increases to efficiencies that could be expanded throughout the healthcare system. The Accountable Care Organization is a delivery system of physicians, hospitals, and other healthcare providers who work collaboratively to manage and coordinate the care of a patient population. The point of this collaboration is to ensure appropriateness of care, elimination of duplicate services, and prevention of medical errors for a population of patients. Examples of various ACOs are listed here that are currently being tested. Here are some other non-demonstration pay-for-performance programs. Hospital Value-Based Purchasing is a CMS initiative that rewards acute care hospitals with incentive payments based on how closely best clinical practices are followed and how well hospitals enhance patients' experience of care during hospital stays. Hospital Readmission Reduction Program will reduce payment to the hospital for high rates of avoidable readmissions for heart attack, heart failure, and pneumonia, and expanding to COPD and total hips and total knees. Physician quality reporting provides financial incentives to physicians for reporting quality data to CMS. In 2015, initiatives were eliminated and Medicare payments were reduced for those physicians who did not satisfactorily report quality data. CMS used lessons learned from the first bundled payments for care improvements models to launch the Bundled Payment for Care Improvement Advanced Model in 2018. The Advanced Model operates under a total cost of care concept in which the total Medicare fee-for-service spending on all items and services furnished to a beneficiary during a clinical episode, including outlier payments, will be part of the episode expenditures for purposes of the target price and reconciliation. An example of that is the Comprehensive Care for Joint Replacement model that aims to support better and more efficient care for beneficiaries undergoing the most common inpatient surgeries for Medicare beneficiaries, hip and knee replacements, also called lower extremity joint replacements. The standardized quality measures are a critical component of the CMS initiatives. Quality measures are tools that help us measure or quantify healthcare processes, outcomes, patient perceptions, and organizational structure and/or systems that are associated with the ability to provide high-quality healthcare and/or that relate to one or more quality goals for healthcare. So the key points to study include: what is an ACO? What is the ACA designed to do? Volume-based payments, and how does quality play a role? Question for section 1.8 is, what is the intended outcome of collaborations made through an ACO? The correct answer is number 1. By meeting established benchmarks for quality and efficiency, participating organizations may receive a share of the savings generated by reducing duplicative services, improving productivity, minimizing paperwork, and other cost efficiencies. In section 1.9, we'll discuss the basics of the financial reports, gross AR, and net AR. Financial reports is to present information that may be used by others to make determinations regarding the financial status of an organization. Financial reports are governed by a number of regulations, including those defined by the Securities and Exchange Commission, the Financial Accounting Standards Board, and generally accepted accounting principles. The income statement ties to the balance sheet and is a summary of revenues and expenses showing any excess or loss from operations. The balance sheet is the statement of the organization's wealth showing assets, liabilities, and equity. The cash flow statement shows how cash was used for the period. Reserve amounts on the financial statement include bad debt, charity, and contractual allowances. In accrual accounting, revenue is recorded when it is earned to permit the alignment of revenue with the associated expenses. Healthcare providers generally use accrual accounting. Cash accounting records revenue when payment is received. And fund accounting is a record-keeping method to manage categories of net assets to ensure compliance with the restrictions on those funds. To accurately report revenue, a provider must be able to calculate the difference between gross revenue and net revenue. To determine net revenue, financial services must estimate the dollar amount of contractual discounts or other allowances that will be applied against those revenues. With the implementation of ASC 606, change to the accounting rules governing the calculation of net revenue, revenue cycle may continue to use the terminologies of contractual adjustments, bad debt, and charity, but the finance terminology and methodologies will be changed. These changes are reflected in a change in the financial statement presentations concerning net revenue. ASC 606 creates two types of adjustments to incurred charges: explicit price concessions and implicit price concessions. Explicit price concessions represent the discounted contractual agreements between the provider and the payers which specify the payments due from the payers. Implicit price concessions are applied to amounts that are expected to be paid by the patients based on the expected payment results for a specific financial class. These allowances constitute the difference between the total amount billed and the amount that a third-party payer and/or self-pay patient has committed to pay based on an agreement with the provider. The course has more information and examples that you should review. Bad debt represents the portion of the patient liability which cannot be collected from the patient. These amounts represent a failure to pay and not an inability to pay on the part of the patient. Charity care represents care provided to a patient who does not have the ability to pay for the services or a portion of the services received. As you move on, please keep in mind the following points. In order to report a provider's revenue accurately, it is important to calculate the difference between gross revenue and net revenue. To determine gross revenue, the charges for all services that a patient has received is totaled. To determine net revenue, financial services estimate the dollar amount of contractual, discount, or other allowances that will be applied against those revenues. The question for section 1.9 is, which of these statements describes the new methodology for net patient revenue? The answer is number 3. Net patient services revenue is now defined as the total incurred charges less the explicit price concession, less any applicable implicit price concessions as applied to the specific portfolio of accounts. In section 1.10, we will address key performance indicators and benchmarking and revenue cycle management. We will also discuss the various techniques used to measure revenue cycle management. The hospital and system map keys are strategic KPIs that set the standard for patient-centric revenue cycle excellence in the healthcare industry, developed by industry leaders and led by HFMA. These industry standard metrics represent the revenue KPIs. The keys define the essentials of revenue cycle performance in clear, consistent, and unbiased terms. Here are some key benchmarks that should be utilized to analyze AR within a provider organization. The keys define the essentials of revenue cycle performance in clear, consistent, and unbiased terms. The keys consist of 25 KPIs divided into 5 major groups. Those groups include patient access, pre-billing, claims, account resolution, and financial management. Key performance indicators set standards for accounts receivable and provide a method of measuring the collection and control of accounts receivables. Benchmarking is used to compare key performance indicators in an organization to an agreed upon average or expected standards within the same industry. The days of revenue in receivables is also known as AR days. This measure is widely used throughout the healthcare profession to measure how fast receivables are collected. AR aging analysis divides the accounts receivable into 30, 60, 90, 120 days and over categories based on the date of service or date of discharge. The AR may also be aged from bill date. However, this presentation completely masks the impact of any processing delays that occur between completion of the service and production of the bill. It is important to age from date of service to understand the impact that timely billing or lack of timely billing has on collection of accounts receivable. The discharge not final billed, DNFB, is the portion of the accounts receivable that identifies charges for patients where services are completed but the healthcare facility has not been able to bill the claim. There are a number of activities that must be completed before bill submission can take place. These include the completion of all charging, final medical record coding, and could include insurance verification activities. Because healthcare is not typically cash upfront business, there is a cost to collect for services rendered. This cost is calculated by dividing the total patient financial services operating expenses by the gross patient care collections for that same period. Patient financial services expenses must also include admitting. The cash collected as a percentage of the net revenue is also known as the net collection rate. It lets you know how much actual cash you collected as a percentage of what was available to collect. It is the ratio of cash to net revenue. Less than 2% of claims should be denied on the first submission. And credit balances should be resolved timely and should be benchmarked at less than 1% of the days outstanding in the accounts receivable. Key concepts for this section include what are KPIs and be sure to understand the days in AR, the AR calculation, and AR analysis. Our final question for section 1 is what are KPIs? The correct answer is number 2, key performance indicators set standards for accounts receivable and provide a method of measuring the collection and control of AR. Thank you for your time and attention to the important aspects of Medicare compliance, ethics, value financial overview, and key performance indicators.